guys, and welcome to week 2. This week we're going to get started on chapter 20. It is a very dense chapter. It has a lot of information. I'm going to go through it slowly but thoroughly. We're going to break up this chapter into different lessons, and that way it won't be too bad. I'm also going to go in order, so I hope that helps. All right, let's start. So, imaging modalities. There are two main types of imaging modalities, ionizing and non-ionizing. So, the ionizing imaging studies include conventional radiography, computed tomography, nuclear medicine imaging. What this means is that it uses radiation. Non-ionizing imaging studies do not use radiation to acquire these images. Let's go over each one. So, conventional radiography. We're talking about x-rays here. Pretty simple. It looks like this chest x-ray that you see here on the screen. You only get 2D images. Usually doesn't require a lot of energy to get an image, and depending on how high the energy is for the image, then then you'll get more information or less information. So higher energies like KVs are going to give you clearer bone definition. Lower energies like MVs, it's going to be a little bit blurrier and more difficult to differentiate between the different structures. Computed tomography, CT scans. So CT is basically x-rays interact with detectors. They attenuate through the different body tissues, and these detectors are way more sensitive to radiation than x-ray film. That's why you get so much more information from a CT scan. The details are actually 10 to 20 times better than that of a regular x-ray. And the CT scale, which is what we went over last week, the Hounsfield units in a CT scan, you're able to see air is black, dense bone is white, and then water or soft tissue or fat as different shades of gray. Nuclear medicine imaging, mainly positron emission tomography, so PET scans. What's happening in nuclear medicine? You're actually using radioisotopes to delineate where there is activity, or tumor activity in this case. So the radioisotope is injected into the patient, it circulates to the body, and it emits positively charged electrons. These are known as positrons. The positrons collide with conventional electrons, and they cause the release of gamma rays. And then these gamma rays are detected. And these PET scans, so I have the image down here. Let me move myself. So PET scans, they are actually able to show you where there's activity going on. So in this case, there's activity lighting up here in this part of the body and here in these parts of the heart, near the heart. But then what they do nowadays is you actually get a PET CT done. So they do the PET scan where the gamma ray activity is detected, but at the same time you get a CT scan in the same position, which looks like this, and then they fuse them together. And that way, not only do you see activity going on, you know exactly where the activity is going on. So very useful when it comes to detecting, diagnosing, pinpointing, delineating, whatever word you want to use, to basically know where there is tumor activity. Magnetic resonance imaging. So now we're going to move into the non-ionizing ones, the ones that don't use radiation. So MRI. MRI works based on magnets, magnetic properties of hydrogen nuclei to be exact. So the patient, you pulse them with radio waves. This causes the nuclei to send out a weak radio signal, which is detected and reworked into a planar image. The images look like a CT scan, but they actually, MRIs have this huge advantage of being able to delineate soft tissue so much better than X-ray, or so much better than CT, I'm sorry. So in MRIs, you can really see the differences in like the different folds of the brain. You see the soft tissue, muscle, all of that is way much easier to detect in MRI. And then, of course, it has its drawbacks. It's actually a lot more expensive. It takes a lot more time to do an MRI than it takes to do a CT. But again, no radiation. So pros and cons. Depends what you're trying to image, really. But each type of modality has, of course, their own benefits and their own drawbacks. Finally, ultrasound. Ultrasound is high-frequency sound waves where a transducer actually releases these waves or produces these waves, and then it actually the waves go through the body, the different tissues, and they bounce back. Depending on the density of the tissue, they bounce back differently. So the transducer picks up on these waves after they bounce back, and it's able to produce an image based on how these sound waves interacted with the different densities of tissue. The ultrasound can give you two-dimensional images, and it can also give you moving images. And again, no radiation. It's not invasive. It doesn't, you can use sound waves all you want. It's not going to have any harm onto the person. The ionizing imaging studies, as much as it's not necessarily extremely harmful, you are still using radiation. So you have to use them carefully. You have to practice ALARA. Okay, the next part of the book actually goes into anatomic positioning and into body cavities. I did cover that in last week's lesson, so I'm not going to cover it today because I don't want this video to be half an hour long. I'm trying to keep it under. So moving right along to body habitus. Everyone has the same organs, but the organs are not all in the exact same place. So the physique or the body habitus can be classified into 4 major groups. You have the hypersthenic habitus. This is 5% of the population, short, wide trunk, great body weight, heavy skeletal framework. There's an abdomen with great capacity, and the alimentary tract is high. So the stomach is almost sitting up in the thoracic area of the body, and the pelvic cavity is small. Basically, I like to think of this, the way I like to remember this is short and great body weight. So we're talking about a person that tends to be wider and pretty short. So it actually ends up squishing your thoracic cavity and your abdominal pelvic cavity kind of really close together. The sthenic habitus. So this is 50% of the population. This is the most common type of body physique. These are well-built individuals, but they're still heavy skeletal framework. You have a high alimentary tract, but the stomach is lower in the trunk than the hypersthenic. Why? Because they tend to be a little bit longer people. You know, their torsos are longer, so their alimentary tract tends to be a little bit lower than in the hypersthenic. For the asthenic habitus, 10% of the population, you're talking about a slender physique, light body weight, light skeletal framework, long, narrow lungs, pelvis with a great capacity, and the alimentary tract is lowest of all types. So this is you're thinking about very skinny people, and the way that the body organs are distributed, their stomach tends to lie very low, almost like into their pelvic cavity. And finally, the hyposthenic habitus, 35% of the population, talking average physique. And then the abdominal cavity is actually so long that it's actually taking up part of the superior portion of the abdomen and the inferior part of the abdomen, similar to, or it's actually sandwiched right in between the sthenic and the asthenic habitus. The lymphatic system. All right. The lymphatic system, it is so important that we understand what it is, how it works, and we're going to be covering the different areas of the body that have different groups of lymphatics. The reason is because many tumors spread through this system. This is usually the first pit stop of a tumor. When it wants to spread, it starts through the lymphatic system. So with that being said, the lymphatic system consists of lymphatic vessels, lymphatic organs, and the fluid that circulates through it, which is called lymph. It is closely associated to the cardiovascular system. The reason being is because these vessels flow really close to vascular vessels. And what it's doing, it's filtering out, well, let's talk about the functions. So it drains tissue spaces of interstitial fluid, it filters it, and it returns it to the bloodstream. So between these cells, the interstitial fluid, it basically takes it out, it filters it, it cleans it up, and then it returns it back into the bloodstream. The lymphatic system also absorbs fat and then transports them back into the bloodstream, and it plays a major role in the body's defense and immunity. Lymphatic vessels. These are basically like the roadways that contain the lymph. The lymph is the excessive tissue fluid that consists mostly of water and plasma proteins. The only reason it's not called blood is because it doesn't have the same elements as blood. but it's very similar in the sense that it's almost like a vein or like an artery. It's called a lymphatic vessel, though, because it doesn't contain the elements of blood. It contains just water and plasma proteins from capillaries. Lymphatic vessels start in the spaces between the cells, and at that point they are so small that they're known as lymphatic capillaries. And then these accompany vascular vessels. So where you see a lot of vascular vessels, you're going to see a lot of the lymphatic vessels. Where you don't see a lot of vascular vessels, you're not going to see lymphatic vessels. So examples of avascular areas are the central nervous system and bone marrow. So you're not going to see a lot of lymphatic activity there. And then another thing is that the flow of lymph is only in one direction by means of one-way valves, so very similar to veins. And then all these vessels flow in one direction, and they empty into either the thoracic duct and the right lymphatic duct, which we're going to go over next. So lymph nodes. Lymph nodes are 2 to 30 millimeters in length. They often occur in groups. And the way that lymph enters the node is it comes in through an afferent lymphatic vessels. These are the vessels are going into a node. Inside of the node is where the draining, the filtering, all of that is happening. And then the lymph, after it has been filtered, exits through an efferent lymph vessel. So there are more afferent lymph vessels going into the node than there are efferent lymph vessels coming out. And what happens is kind of a bottleneck effect. These afferent lymph vessels all throw their lymph into the node, and because there's only one way out, or less ways out, I should say, it allows the lymph node time to really filter out the lymph. And now for the lymphatic organs. So we have the spleen. The spleen is the largest mass of lymphatic tissue in the body. It's about 12 centimeters in length. It actually sits right behind your stomach, so to the right, to the left of your body, posterior to the stomach. You're going to see it in CT. We're going to go over it during the live session. And it actively filters blood, it removes old red blood cells, and it manufactures lymphocytes for immunity surveillance, and it stores blood. Now, something very ironic, it is a lymphatic organ, but it does not filter lymph. Lymph is filtered by lymph nodes. The spleen filters blood. So very different. Another organ is your thymus. The thymus is a gland, actually. It's located it's along the trachea, so along the airway. It's superior to the heart and posterior to the sternum. Your sternum is right here on your chest, so it sits around here. And it's actually more active in pediatric immunity, so it's a gland that's very active when you're a child. As you grow older, it actually gets smaller and its function becomes very little. And it serves as a site where the T lymphocytes can mature. Next, you have the tonsils. So there are three groups of tonsils. You have the pharyngeal tonsils, which are actually called, they're also called the adenoids. Those are in your nasopharynx. The palatine tonsils are in the oropharynx, and the lingual tonsils are the ones that are at the base of the tongue. Those are the ones that you can see when you open your mouth. And these tonsils are there to protect against foreign bodies. Next, we have the thoracic duct. So we mentioned that previously. These lymph vessels, there's afferent vessels that go into the lymph node. Then the efferent vessel takes the lymph out of the lymph node. Ultimately, all these efferent vessels meet together at the thoracic duct or the right lymphatic duct, either or. And that is where they dump most of their lymph. And then it depends on what part of the body which duct is serving. So the thoracic duct serves the lower extremities, the abdomen, the left arm, and the left side of the head and neck. And it drains into the left subclavian vein. So this duct is a lot bigger than the right lymphatic duct, because the right lymphatic duct only serves the right arm and the right side of the head and neck. And then that one dumps its lymph into the right subclavian vein. And the the subclavian veins then drain into the heart by the way of the superior vena cava. So that is where the lymph is eventually returned into the bloodstream. And then up here I have a very good and interesting question, very pertinent to us as radiation therapists. So what is lymphedema? Lymphedema is a lymphatic obstruction. It's a condition of localized fluid retention. So this happens when your nodes are not able to filter lymph. And what happens is there's a buildup of lymph, and there is what we call edema. So there's swelling. This is something that we see very common, is very often. It's very common when you're treating breast cancer. Women with breast cancer, when they are diagnosed and they have to go get a biopsy done, because the lymphatic system tends to be the first road of the first option for metastasis in breast cancer. They usually will biopsy the tumor, the lump on the breast, and they'll also biopsy some of the lymph nodes. When they biopsy these lymph nodes, sometimes they remove them. And what happens is you have less lymph nodes, and then the same amount of lymph is still flowing through your body. So there tends to be kind of, again, like a bottleneck effect. So there's all this lymph that is accumulating and building up, and it just takes longer for that lymph to travel through the few remaining nodes that are there. And what happens is there's swelling, and it tends to happen on the arm. So when you're treating a patient with breast cancer, it is very common that on the ipsilateral arm, there's going to be swelling. And the way that they help this condition is they wear sleeves. These like compression sleeves that help keep the lymph flowing, keep the lymph moving. And so, yeah, typically breast cancer, and only on the ipsilateral arm. The contralateral arm and contralateral breast are usually fine. All right, we have made it to the axial skeleton. All right, so the skull. The skull is made up of 22 bones, 8 cranial bones, 14 facial bones. So let's go over the cranial bones. You have the frontal bone, one single frontal bone. You have 2 parietal bones, these yellow ones, 2, so that's 3 so far. You have 2 temporal bones, these pink ones, so 1, 2, that's 5 so far. You have 1 occipital bone, which is the one in the back of the head. You have a sphenoid, which you can't really see it in this image, but sits right behind the ear, kind of, and the ethmoid bone, which also sits behind the nose. Sorry, did I say the sphenoid sits behind the ear? Sorry. The sphenoid sits behind the orbits and behind the nose, and the ethmoid sits right behind the nose. Okay, so I think right here, here's the sphenoid. You could see it here in the orange. And then the ethmoid, if I'm not mistaken, yes, it is this little blue one here. Those are your cranial bones. Then you have 14 facial bones, which I'm gonna reference the book on this one. The 14 nasal bones are the 2 maxillary bones. So here, maxillary. Zygomatic bones, these are the yellow ones, which is where your cheekbones, they're known as the zygomatic bones. The nasal bones, so these little green ones inside of your nose. 2 lacrimal bones. So the lacrimal bones are these dark purple ones sitting here right next to your orbits. The way I remember lacrimal is because in Spanish, lagrima is tear. Sounds very similar to lacrimal. And it's basically where your ducts sit. So right next to your orbits. 2 palatine bones. You can't see those in this picture, but palatine are in your palate. So on the roof of your mouth. And 2 inferior conchae, which are right here. Also part of the nose in your nose, the bones in your nose. 1 vomer, another part of the bones inside your nose. And the mandible. The mandible, this is your jaw. Your jaw, very important. It's the only one that is actually not joined by a suture. So suture, jumping into the next part, these are fibrous joints that join the cranial bones. You're going to have 4 total sutures. You're going to have the coronal suture. The coronal suture, coronal, if you remember from last week, the coronal plane divides your body from anterior to posterior. So the coronal suture is going to do exactly the same with your bones, your cranial bones. It's going to separate the anterior from the posterior. The sagittal suture, there's not a picture of it on these, but it actually sits between the 2 parietal bones. So when these 2 bones meet right back here after the frontal, this will be your sagittal suture, and it separates your bones, your skull from left to right. The lambdoidal suture is the posterior portion of the skull and lies between the parietal and the occipital. So it's actually this one that separates the parietal bone from the occipital bone, lambdoidal suture. And finally, your squamous suture is here. It separates your temporal bone from your parietal bone. And I believe, I want to say, it's the mandible and the ossicles, which are the bones in your middle ear. Those are the only ones that are not joined by sutures. Sorry, before I said it was only the mandible, but it's actually 2. The mandible and the ossicles. All right. Moving right along, the paranasal sinuses. So these are air-filled spaces in several bones of the skull. These are so important because you see them so easily in CT scans. So when you're a therapist and you're scanning patients, you're going to be able to see these right away in a CT scan of the skull. We're going to go over them next week during the live session. And it's so important that you know them. It's so important that you know how to identify them. And their names are pretty easy to remember if you know where these areas of these bones are. Where these bones are is where these sinuses lie. So the frontal sinus, very close to your frontal, the frontal bone, the frontal bone. So these sit right above your orbit. You're going to have 2 of them. And it looks just like this on the sagittal view of a CT scan. It looks just like that. It's going to be your friend. The maxillary sinus, this is the biggest one. They sit in your maxilla. These are like I said, they're pyramid shaped. They're enclosed in the maxilla, and they are the largest of your paranasal sinuses. The ethmoid air cells, so the ethmoid sinus, it's very easy to see in the CT because you see all these little bubbles and they sit right behind the nose. These little bubbles all together form the ethmoid sinus, and your sphenoid sinus is a space that is inside of your sphenoid bone, air-filled space inside of your sphenoid bone, so right more posterior to the ethmoid sinus. All right, we're coming to the end of it. The axial skeleton, now we're going to look at the vertebral column. So there are 3 total vertebrae. You have 33 total vertebrae. You have 7 cervical, right here, the green. You have 12 thoracic, this orange. You have 5 lumbar, the red. You have your sacrum, which consists of 5 fused vertebrae. And you have your coccyx, which consists of 4 fused vertebrae. Characteristics of your vertebral bodies. So we're going to go over these during the live lesson because I don't have a picture up here, but the vertebral foramen is actually the passage through which the spinal cord passes. And you can see it here. These little holes here are all the vertebral foramens of each one of these vertebral bodies. Or each one of these vertebrae, I should say. That is where the spinal cord goes through. And then the spinous and the transverse processes allow for muscle attachment. So in this view, you can see the transverse process sticking out on the sides. And in this view, which is a lateral view of it, you can see the spinous processes sticking out through the back. The nerves terminate at the cauda equina, and that's actually in your L spine. So around L3, L4 is where you see the cauda equina, and that's where the nerves, the spinal cord and the nerves of the spinal cord end. And then there's different types of curves. There's different curves associated to your spinal cord, to your vertebral column. We have the primary and the secondary vertebral curves. The primary vertebral curves are developed in utero. These are present at birth. Everybody's born with these. The thoracic curve, which is this It's concave if you're looking at it anteriorly. So anteriorly, if you're looking at it from this view, this way, it's a concave curve that you are born with. And the pelvic curve is also concave. And this one is very obvious because these are fused bones. These don't separate. There's no other direction for these to go. And then the compensatory or the secondary vertebral curves, these develop after birth when a child learns to sit and walk. So depending on how you learn to sit and walk, these are going to be curved. The severity of these curves is going to vary. So your cervical curve, it's convex in the anterior view. It's actually convex. And so is the lumbar curvature. And these, again, these will depend on how you develop, how you walk, how you sit. And let's see, the vertebral column. There's also curvatures that are not normal or not average. These are when you see kyphosis, lordosis, or scoliosis. So kyphosis is an excessive curvature that is concave anteriorly. So kyphosis is this middle picture here. If you're looking at it from the anterior, you have an excessive curvature concavely in the concave direction, usually seen in your T-spine. When you have a kyphotic patient, which you have tons, it is very hard to lay them down flat. As a therapist, you're trying to straighten a patient out, you're trying to get them to lie flat. If you have to make a mask, if they're very kyphotic, it's going to be very difficult to lie them down flat. So you get very creative with things to put under their head to help them lie on the table. Lordosis is an excessive convexity of the lumbar curve anteriorly. So this is what kind of when you're sticking your behind out a little too much, that causes lordosis. And scoliosis is an abnormal lateral curvature. I'm sure you guys have seen this. You're going to see this in many patients. They lie down and there is a curve either to the right or to the left of the vertebral column. Spondylolisthesis it occurs when one of the spine's vertebrae slips forward over the vertebra beneath it. So basically this vertebra is slipping forward and it's causing a nerve to pinch back here. You're able to see this in X-ray as well. Finally, the thorax. The thorax right here, it consists of the sternum, costal cartilage, which is all the blue, the ribs, which is 12 of them, and the thoracic vertebrae, which again is 12 of them. The thorax encloses and protects the organs in the thoracic cavity and the upper abdomen, and it provides support for the pectoral girdle and the upper extremities. So your sternum, you have the manubrium, which is the top part. You have the body, the middle part, the biggest part, and the xiphoid process. It's this little spiny part. The suprasternal notch, it's at the level of T2. It sits right between the two clavicles, and you can feel it on yourself. It's literally this little hole right here. The suprasternal notch is something that we use as therapists to make sure that the patient is lying straight on the table. The angle of Louis is the biggest curve of the sternum, and it's usually at the level of T4. Your vertebral sternal ribs are ribs 1 through 7. So what this means is that they start at the vertebra and they end at the sternum. So vertebrosternal ribs, T1 to T7. Vertebrochondral ribs are from T8 to T10. And what happens with these is that they start at the vertebral body, but they don't end at the actual sternum. They actually end at the cartilage. So that's why they're called vertebrochondral ribs. And T11 and T12 are your floating ribs. Those are also going to help you kind of situate yourself inside of the patient's body to see what level you're looking at when you're scrolling through CT scans. And that's it. That's all I have for this week. We will meet together during the live session to go over more scans and being able to identify these different areas, and we're going to hit these areas hard in terms of going over scans and being able to identify all the structures that I went over today. Feel free to email me with any questions, and have a great day, guys. Thank you.